All right. Good evening and welcome to this live stream. My name is New York State Assemblyman Doug Smith, and I'm here to welcome you to the Long Island Community Hospital Long Island COVID-19 update. We are so fortunate to be joined by a number of fantastic people tonight. I would first like to take a moment to thank the hardworking members of my COVID-19 Emergency Small Business Task Force. I'd like to thank Jim Cotgreave of Cotgreave Insurance, the chairman of the task force and former president of the Ronkonkoma Chamber of Commerce. I'd like to thank Rick Amirati, the current president of the Holbrook Chamber of Commerce, Kevin Himes, president of the Ronkonkoma Chamber of Commerce, Mike Wentz, president of the Farmingville Hills Chamber of Commerce, Lenore Paprocki, president of the Middle Country Chamber of Commerce, as well as our task force members, Kevin Guilfoyle, Diane Cadulo, Tom Lohr, Marissa Paiza, and Suffolk County Legislator Anthony Piccirillo. I would like to take a moment to also specially thank Marissa Paiza. As a member of this task force, Marissa has spent a fantastic amount of her time working with Long Island Community Hospital and putting this together, as well as Caroline Villegas, who I've known for a number of years and who has been a very active member of our Chambers of Commerce on behalf of Long Island Community Hospital. So first, I would like to turn it over to Cynthia Ruff, who is the Vice President of Branding and Stakeholder Relations, who is going to introduce President Richard Margulis and Dr. Dean Babich, the Chairman of the Department of Medicine at Long Island Community Hospital. So thank you and welcome, Cynthia.
Thank you. Hello, everyone. I'm happy to represent Long Island Community Hospital, a hospital that stood strong against COVID-19, especially tonight as we are celebrating Heroes Week. When you have a minute, check out our social media and you can see how we're showing our gratitude to our staff. I have the pleasure of introducing two crucial leaders and Long Island Community Hospital heroes. First, Mr. Richard Margulis. Not only is he our president and CEO, but he also actively and tirelessly led our COVID-19 task force 24 hours a day, 7 days a week. He is an incredibly engaged leader who dives deep to ensure all important decisions are factored based on what is best for this community and our organization. And then Dr. Babich, our chair of internal medicine, he helps lead our quality efforts, shows his care and compassion for all his patients, and is also a member of the COVID-19 task force. As he's answering your questions later on, keep in mind he's had a bird's eye view of this pandemic. To date, we've discharged over 718 patients. These were not just treat and release patients, these were hospital stays. And I have no doubt that we were able to do that because of Dr. Babich and Mr. Margulis' leadership. So first, we're going to hand it over to Mr. Margulis so he can share the events as they unfolded here at Long Island Community Hospital.
Okay, thank you, Cynthia, for that introduction. A little bit too much on the positive side there, but thank you very much. The real heroes are our employees, our nurses, our frontline staff, our doctors. Before I give you a little overview of that period of time from March through the end of May of this year, I want to thank Assemblyman Smith for the opportunity to address this crowd tonight, esteemed leaders of the civic associations. Nice to be here, nice to talk to you, nice to see you. So we go back to January of this year when we started to hear about this potential COVID-19. And I would tell you that in our conference room, or our war room that it turned out to be, we've faced many different types of urgent situations, many different types of illness or threats of major disease over the years. We have a very, very well-established emergency management plan. We have Michelle Miller, who is our emergency manager here at the hospital, does a phenomenal job. And in our preparation, I would say to you that this plan covers 85 to 90% of any type of emergency. It's really process-driven. It's a follow the numbers type of an approach, and then 10 to 15% of the time you just have to modify it for the type of disaster or event that you're dealing with. So back in late January, we started to talk about this. Quite frankly, I think everybody who was sitting around at our table participating, we were taking it serious, of course, but we've been through SARS, we've been through Ebola, H1N1, we've been through September 11th, other major emergencies, disasters. So we're prepared at least somewhat, and I would say somewhat because we think we were prepared. And as we moved forward through January, every Monday we would dedicate part of our staff meeting time just to talk about some of the what ifs. And as we moved through in February, those what ifs started to become real potential and real concern for everybody. We're listening to the news, we're getting information from the CDC, from the federal government, from CMS, from New York State. And I would tell you that we start to become keenly aware of what could possibly happen. I say keenly aware because now, some 9 months later, I would say to you that we were naive in our approach. Well prepared, but naive. So let me just give you some numbers as of today. So worldwide today, there are 41 million cases confirmed of COVID-19, with 1.1 million deaths worldwide. The United States has approximately 8.3 million positive cases with 222,000 deaths. New York State has 488,000 with about 506 deaths. New York City has about 256,000 cases with 23,000 deaths. Nassau County has 49,000 confirmed cases, 2,200 expirations. Suffolk County, 48,000 with about 2,000. What's very interesting about those numbers, and they're staggering numbers for 2020 to be in this type of a situation, is that of New York State's 506,000 cases, I'm sorry, I misrepresented that, 506,000 cases in New York with about 488 deaths. New York City, Nassau, and Suffolk County account for about 360 of New York State's total 506 cases. Today, that for us is a major driver because what we witnessed was during the height of this pandemic, we saw the wave from New York City move right on out through Nassau County and Suffolk County. And it hit Nassau County about 4 weeks after, and it hit us about 2 weeks after that. So we go back to our planning table. We don't know what's coming at us. We're preparing, we're buying additional supplies. We're starting to think about staffing. How do you cohort? How do you put like patients together? But the reality of this happened in early March when we had our first positive COVID patient come through our emergency room. So our hospital is licensed for 306 beds. We operate about 250 beds on any given day. We see about 185 patients a day in a 24-hour period through our emergency room. We have 24 critical care beds licensed in our hospital. We have the supplies and inventory in terms of respirators to handle about 25 respirator-dependent patients on any given day, and that's a busy day, 25. So we're going through our planning exercises where, again, we're looking at our emergency management plan. We're starting to communicate to our clinical folks, to our staff, starting to take really the communication aspect of this and the preparation of this to the next level. We're following the CDC guidelines at all times. We're working with our elected officials, and we're very grateful for the support that we receive with PPE. We're reaching out to our community. We're starting to talk more to external leaders in our community and starting to look at what is the actual plan for if this should develop further. So the first thing that we did was we established a forward triage, where we were screening patients before they came into our hospital. We had to identify those patients so that they wouldn't infect employees, they wouldn't infect other staff, and more importantly, they wouldn't infect the emergency room. We started to create additional intensive care unit space. This was a critical step for us. At this point, early March, I don't think we realized what the demand would be for intensive care unit beds. We started to order medications and to start to stockpile medications. I'll tell you that Dr. Babich, Dr. Webe, as our senior medical officials, were very much ahead of the curve there. We started to look for additional ventilators, additional other supplies. Everybody in the world now knows what PPE is. On January 30th of this year, nobody knew, or relatively few people knew what PPE is. We quickly found out that in terms of the N95 mask, which was the required mask, the small size was going to be in great demand. So we kind of set the stage here. We start to look at our clinical policies and procedures that I'm sure Dr. Babich will talk about more later. Early on, there are not enough test kits. So patients who are coming in are being treated primarily clinically based upon presenting symptoms, where we were not going to use a test on a patient if we felt the patient was clinically positive. That became a major concern for us. We started out having about 10 to 12 tests a day available to us. The turnaround time at that point was 8+ days. So now we're treating patients in the hospital for 8 days, and we really don't know whether they're positive other than clinical symptoms, but they're occupying space, and we have to make sure that we use additional PPE, et cetera. So we start to look at what's going to be necessary. Now, what's happening is we're into the second week of March. We're listening to everybody else. We're on regular conference calls with the governor, as well as the health commissioner, Dr. Zucker. We're participating at every level of government, every level in community support, working with our EMS company, the police department, fire departments. A real strong bond occurs here. Now, what's very interesting about emergency management is really leadership steps back and facilitates what the staff needs at that moment. And I would tell you that our staff is an amazing staff. There are no words that I can speak to really demonstrate who they are and what they are. I can tell you that everybody in our organization, everybody in any healthcare organization, had a moment of time where they became concerned not only for their own health, but for their family's health. And that became an emotional issue for many staff. I remember one morning coming into the hospital early, and there was a car parked, and there was a nurse, or a young woman sitting in the driver's seat, and she was sitting there, and she had her head in her hands, and I was observing this. I walked over to the car, I said hello, and this nurse was sitting there crying in the front seat of her car. And I looked at her, and I said, what can I do to help you here? She said, I'm just so nervous. I have to come to work, but I'm so worried about myself, and I'm worried about bringing this home to my family. And I looked at her and I said, look, if that's how you feel, it's okay, go home. She turned to me and she looked at me and she said, no, I'm a nurse. I have to go in there now, and I have to take care of my patients today. And she did. That's what happened. And that's just one story of the Herculean efforts that these people, these heroes, displayed every day. It was truly an emotional journey. It was touching. So I kind of set the stage here. I hope everybody can feel that, feel the commitment of our staff. And it didn't matter whether you sat at the front desk, you were helping keep the facility clean, which all of a sudden raised to a new level of anxiety, number one, and attention, because we needed to combat this disease in our home here. We need to make sure that we were cleaning appropriately, we were recycling our rooms the right way, we were taking care of our staff, and we had the right supplies. So our job, and I call it the 100-day pandemic for us, even though we're still actively involved in this pandemic. But we had an acute phase of this pandemic from the beginning of March right on through to the end of May. About 100 days. Our focus during that time, every day, 24 hours a day, 7 days a week, was one, to communicate to our staff and our stakeholders, internal and external. It was also to make sure that we procured enough PPE. We were on the phone 24 hours a day, 7 days a week, talking to places, talking to contractors or companies in Vietnam, Thailand, China, India, to be able to source materials. We worked proactively through the Suffolk County Office of Emergency Management. We were working directly with the governor's office, and again, our elected officials, federal, state, were just, they were heroes as well because they were helping us procure this PPE equipment. We started to have to really focus on how are we going to treat these patients clinically, and Dr. Babich will talk more about that in a few minutes. But we had to start to go through some exercises that really revolved around the ethical use of resources. And as much as physicians are healers, and they're trained in taking care of and treating patients, they're also trained in compassionate healers in terms of looking at patients and helping patients and their families make it through and come through such a disease or possibly not survive. But it became apparent quickly that there were not going to be enough respirators in the state of New York. There were not going to be enough hospital beds, intensive care unit beds, enough PPE. I do recall a telephone conversation that I was on with the governor and the commissioner of health. And the commissioner of health turned to us and said, we're on our own. We have to work as a state because there's nothing else that's there. Everybody's doing everything they possibly can do. So our medical staff had to start to look at how would we, if we got to this point, how would we ration ventilators? Who would go on a ventilator? Who would stay on a ventilator? We were having problems procuring the medications that sedate patients when they're being ventilated. We had to outsource that. This became a monumental task of our medical staff. And I would tell you that our 550 plus physicians, there is not one doctor. It didn't matter whether you were an anesthesiologist, the chairman of internal medicine, a surgeon. Everybody stepped in and stepped up and did what needed to be done for patient care and to support the community. And our community is about 400,000 lives. But these were decisions that were ethical decisions that had to be made. I would tell you, fortunately for us, we never had to implement those decisions, but we were ready. And that's what was key. So as this is progressing, painted the stage, we're outreaching to stakeholders, but some other wonderful things start to occur. And that is that the community starts to respond to the heroes in the hospital. I would tell you that our kitchen, I do not think, had to prepare a meal for 90 days straight. There was more food, more energy drinks, soda, snacks, salads, desserts, cakes, cookies coming into our hospitals. Matter of fact, you have to find a moment to smile or to laugh a little bit. And they talk about the freshman 15 when you go away to college. It quickly became the COVID-19 because people were able to eat. They were eating on the run, but the community just banded together and provided us this stream, whether it was breakfast, lunch, dinner for our heroes, our frontline staff, our nursing staff, our doctors. Then came things such as gift cards and little gift baskets and little thank yous. In addition, then came masks, face shields. People were using a 3D printer to print shields or make the attachments in the back so that the mask wasn't as tight across somebody's face or the back of their head. You name it, the creativity that was there in our community shined through. We were very fortunate that we had a very philanthropic donor step forward and donated a $500,000 gift to the hospital as a matching gift. And in 3 weeks' time, we raised an additional $600,000. That was the Knapp Family Health COVID-19 Crisis Fund. It was originated through the three foundations, which is the Island Outreach, Knapp Sweezy Foundation, and the Gardner Foundation. We were very appreciative for their support. It was just a Herculean task, again, to be able to raise $1,100,000 to buy PPE. So we're into this. We're moving forward. We're treating patients clinically. To date, we've done about just under 10,000 tests on patients. As Cynthia said before, we've discharged about 718 patients. We've also had about 8,000 COVID encounters, whether that was an inpatient or an outpatient. But we had to reposition our hospital now. The governor had a directive that we needed to increase the capacity of our hospital by 50%. So I mentioned before that our capacity on any given day was 250 patients. That means we had to add an additional 125 beds to be a 375 bed hospital. And then the directive came that really kind of pushed us back a little bit, that the governor wanted another 50%, which would have put us up over 400 beds. Now, we were able to handle the 50% capacity, but our concern was to go up 100%, the staff was not there. We were putting out advertisements on our social media pages for volunteers. The state had done the same thing, created a pool of potential candidates, but it took time to vet those individuals. We were looking for volunteers. We had some volunteers. We were able to obtain temporary staffing that we paid a retainer for to have those people come into our hospital. We started to look at long-term, how would we staff the hospital for a protracted period of time? Because we recognized early that we were going to have to give our staff a break. People couldn't work 4 or 5 12-hour shifts in a row. They had to get home. They had to be able to go home to their families, get away from the hospital environment. So we worked on that. We were successful in that. We brought in additional staffing. We took advantage of some volunteers. The outpouring, as I was mentioning before, now started to turn towards music. So a bagpiper came, asked us if they could come down and play music outside of our front door at change of shift in the evening. We had a DJ who came down. We had car shows. We had the local EMS companies. I think probably about 50 of them showed up and gave us a parade. The sheriff was here. The local fire departments came together. Car clubs came together. All of this was terribly moving and just very emotional, because this was being done out of the goodness of people's hearts. And they were doing it just to give something back, pay it forward, give something back. And as I talk to you, that's one of the most emotional pieces to this, because this really brought out, it's going to sound a little bit unusual, but it truly brought out the best of people. And it gave us something to look at, to care for one another and take care of one another, instead of whatever's happening in our environment outside of healthcare, whatever distraction to the pandemic. And as we would say to people, wear a mask, socially distance yourself, wash your hands often, but be kind, and stay safe. That became our mantra. That became our byline. And it was the case. And I will tell you, another very emotional moment was I left the hospital one night. I'm walking out the front door, and there's a couple parked. Actually, the way they drew attention to themselves was they were parked illegally. So right away I'm looking and I'm saying, who are these people parking here? And they're 2 people, and they're in their middle 70s, and they're holding up signs, and they have balloons. And as people walked into the hospital, they were going woo woo, and they were clapping and applauding. And I had heard about these individuals, but I had not met them. So I walked over, kept my distance, introduced myself, and I asked them, what's your deal? Why are you here? They said, we had to do something. We just couldn't sit home. We just couldn't watch the news anymore. We're quarantining ourselves, but we had to give something back. And those 2 people were just amazing. And they did this every night. They would just show up. I would say about 2 weeks after that, I received the phone call from the gentleman. He's on the phone and he's very emotional with me. And I said, what's the matter? Are you guys okay? Are you sick? Do you need some help? He said, no. He said, my son found out what we were doing. And he told us that we're not allowed to do this anymore. He said, and I'm heartbroken. And he was actually crying on the telephone with me, just to give you a sense of what went through people's minds and what they were focused on. So I try to paint the picture here of what happened. We had employees that were getting ill. All hospitals had employees that were getting ill. We focused again on procuring PPE. making sure that we communicated constantly, taking care of patients, and getting through this every day. And if anybody's ever seen the movie Groundhog Day, again, that's what it was. You woke up after a brief nap, you came into the office, you turned on your Zoom, but you were living the same day over and over for about 100 days. So there was an impact, obviously, on people's lives. We start to come through this in early June. We start to look at, our same task force starts to look at the recovery efforts. But now we're looking at not only the things that I mentioned before, but as I'm sure everybody on this call, everybody in business, everybody in their personal lives, now we're facing different challenges. Now we're facing the fact that there's an economic impact here, that our employees are impacted. We're recognizing post-traumatic stress disorder in the workplace. We mobilized our employee assistance program. A lot of our behavioral health team, we got out onto the floor just to walk around and talk to people. We actually did this throughout the acute phases of the pandemic. We enlisted the help and the support of our religious leaders to come in, our chaplains to talk to people, individual sessions, group sessions, just talk to people. Let people kind of, let the relief valve open a little bit here. So we come through this, we're continuing to secure our PPE. Right now we have in excess of 6 months worth of PPE in inventory. We start to prepare for the future. We have to look at the impact on our institution, our employees, continue to support our employees, still looking at additional staffing to be able to supplement the staffing later this year into 2021. Now the work, I would tell you, quadruples, because not only are we dealing with those items before, but now we're seeing the ramifications of this on multiple levels. I would tell you that we're very proud that even though our business, because our hospital and all hospitals are a business, we've seen a dramatic reduction, as every hospital throughout the country has, in our volume. Who wants to come to a hospital during a COVID pandemic? So now we have to start to let our community know that we're open, we're safe. Fortunately, we have the NAP Cardiac Care Center that by design, we kept that as a non-COVID facility. It has a private entrance, exit, it has exam rooms, it has space to keep patients in. By the way, during that acute phase of the pandemic, there was an order that we had to limit our visitors. At some point, we had no visitors into the hospital. We were not permitted to do elective surgery or elective procedures. For a hospital, that is a revenue opportunity for us. So we look at the volume in our emergency room, as I stated before. We budgeted for 185 visits a day. We're down during the pandemic to 90 patients a day. Half the number of patients are coming through the hospital. The volume in the hospital is lower than normal, but intense. I failed to tell you before that I mentioned we had 24 critical care beds, but a good portion of the time through the 100 days, we had about 100 patients in our hospital. We had upward of 90 patients in a critical care environment, with those 90 patients, 80 plus of those patients being ventilated. And they had to be cared for 24 hours a day, 7 days a week. There were physicians who sat at the bedside of patients throughout the night to make sure that the ventilators were working properly. So I go fast forward now, I come back to our preparation. I'm pleased to tell you that even though there's been an economic downturn in healthcare, our major concern here, though, is really that people are avoiding taking care of themselves. And in early June, we started to see patients who were coming into our hospital very sick, non-COVID related. We're now starting to deal with the post-COVID, positive COVID patient complications, and I'm sure Dr. Babich will talk about that. That's a new dilemma for us, for healthcare overall. We're continuing to see COVID positive patients. Today we have 3 positive patients by test. We have about 20 patients that are people who are under investigation because they're being tested and we don't have results back. Our impact moving forward here is we are planning for an additional second wave of this disease later this year and into the winter. we are hopeful, and by all the science that helps generate our strategy, that this will not be as severe as the first wave here. We're anticipating a super flu season. And again, Dr. Babich, I'm sure, will talk about the combination of flu and the possibility of COVID. So we're preparing our institution. We continue to work with all of our stakeholders. We're focusing really on the mental health of our employees because that has had an impact on our organization. We're intensifying those efforts. We continue to keep PPE. We're renovating our physical plant to make sure that we have the right negative pressure rooms in place, that we can activate all these emergency measures through our emergency management plan really within an hour or so that we can be ready if things start to happen. That's kind of the status of where the hospital is. I would tell you, just in summary here, I could probably speak for 3 hours. And what I probably would not talk to you enough about, and from the bottom of my heart, it is about the people and what people did during this pandemic. We talk, sometimes we hear about terrible things that are happening in society, in our environment, but I would tell you, in our world here, I could not be more proud of the community who responded in kind, our employees who battled through this every day, our medical staff who were heroes, our nurses who just came in here every day, put everything aside, and battled and fought for their patients to do everything they possibly could do to help that patient make it through this terrible disease. We're better for it in the sense that we've learned a lot. Clinically, we've learned how to treat this disease. We're much more advanced now than we were back in January, February, and March. We're better prepared. And my concern really is that this is something that we will face, whether it's COVID or something else, as we move forward into the future. But I guess the bottom line here is we're prepared, we're open. Don't avoid your own healthcare. This is the time, please, to re-engage with your physician, re-engage with the hospital, and know that we're prepared, and we always will be prepared to take care of our community. So I'll stop there, and I appreciate the time.
Thank you so much. And if you're just joining us, Assemblyman Doug Smith here, and that was Mr. Richard Margulis, who is the president and CEO of Long Island Community Hospital in Patchogue. They have done just a tremendous job, as the president just laid out, responding to this pandemic. And I think something that you highlighted just is the humanity of us all, the fact that the people in our community are so giving of themselves in times of need. And I think that's something that's often forgotten, but during times of tragedy, we do see a great outpouring of support. And I think on behalf of the entire community and on behalf of the state of New York, I can tell you we are so grateful for the healthcare heroes and everything that they combated with every single day and continue to deal with. You talked about the mental health issues as well. That's something that going forward, they're going to continue to deal with that. And, the community does support you, and will continue. Now, for this portion of the program, we have questions asked by real Long Islanders that were presented to the Emergency Small Business Task Force that we wanted to ask from the hospital. And again, we're just hearing from President and CEO of Long Island Community Hospital, Richard Margulis, and we are also joined by the Dr. Dean Babich, who is the chairman of the Department of Medicine at Long Island Community Hospital. The first question we have is Chase from Smithtown, and he's asking, we are hearing new reports that children may be more susceptible to get or spread the virus. Can you speak to that, and is that being studied?
Thank you, Assemblyman Smith, and thank you for having me here tonight. Thank you, Mr. Margulis, for and Cynthia for that wonderful introduction, and thank you for calling us heroes. It wasn't just the medical staff or the nurses that were actually the frontline workers. It was the entire hospital. I do want to stress that it was leadership that started with the task force early enough for us to prepare for this pandemic, and it was the environmental services who were doing the terminal cleaning of rooms. It was really a team effort. It was the lab that was performing tests. It was really just the entire organization that was able to pull us through. Before I start answering the questions, I did want to give a little bit of a timeline so you can better understand how quickly these things developed and what stress the staff, the hospital, the organization was under. So our first 2 confirmed cases were actually in March 18th. Those are patients that were admitted approximately 8 days before we had the confirmation of their tests. So they had presented in very early March. At that time, we had 21 ventilators available for use. Within 5 days, we went from those 2 patients to 54 patients. And 3 days later, we were down to 7 ventilators. So in just a very short period of time, we had exhausted a majority of our ventilator supplies, and we had filled the hospital with more than 54 patients. Within another 3 weeks, our ICU had doubled its capacity. So we not only did that first 50%, we were already at our second 50% within the first 3 weeks of the pandemic. We had used our intensivists 24 hours a day. We enrolled our resident staff. We have 30 internal medicine residents who also covered the ICU because that was where a majority of our patients were. We enrolled NPs and PAs, and finally the anesthesia attendings were also helping us to cover the ICU patients. By April 14th, almost 1 month after our initial visits, we had now tripled the capacity of our intensive care unit. There were 71 patients that were housed not only in the physical ICU, but also took up our PACU or post-ambulatory, post-surgical areas, our pre-ambulatory areas, and we even opened a labor and delivery to accommodate more ventilators. We also placed them in the emergency room with a peak of 61 ventilators being used, or 3 times our normal capacity. It would be another month, May 11th, before we would go down to 100%, a normal 100% capacity of our ICU, and another month after that before we could nearly claim that for us, the pandemic was weaning off, and that was in early June. We then came to this post-COVID, or I want to call it a post-COVID and a pre-COVID era, and that is recovering from what we had just gone through and preparing for perhaps our second wave. We moved to continue to protect our staff, our visitors, and our patients. We have screening processes in place for anyone who is entering the building, thermal imaging to look for temperatures, and questionnaires so that we can keep our staff safe, our visitors safe, and our patients safe. Every patient now that is admitted to the hospital has a COVID test so they can be isolated as appropriate. We are now open to elective surgeries, and as Mr. Margulis had mentioned, we are fortunate to have the NAP Center, which is physically separated from the rest of the hospital and was always considered a clean area. All our surgical patients are also tested for COVID so that there are no positive COVIDs going to those clean ORs. We're evaluating treatment options that were not available in the early parts of the early times of the pandemic. I think the only medication we had at that time that was thought to be of promise was hydroxychloroquine, only to find out pretty much in the midst of the pandemic that the medication was not only not doing any good for our patients, but could be causing harm. And so the use of that drug was halted. We did not have access to remdesivir, which is the antiviral, which has been shown to decrease the length of stay for patients in the hospitals and somewhat blunt the overall reaction from the virus. We did, however, have the opportunity to enroll in a study with the Mayo Clinic to use convalescent plasma. So we continue to evaluate the treatment options, which is the remdesivir, shown again to decrease the length of stay and blunt the virus. We're looking at steroids, which are shown to decrease mortality. We're looking at various ways of using oxygen therapy, including high flow, different ventilator settings, and again, the convalescent plasma. We're preparing for the second wave. Mr. Margulis had mentioned the flu. We are pushing the flu vaccine harder this year than any other year. We're looking for 100% compliance among the medical staff here and also within our community. We do not want to have a co-infection with both the flu and COVID-19 because you can be co-infected with both viruses. And we want to be able to differentiate those that have the flu and those that have only COVID because the treatments are different. Tamiflu works for the flu, but it does not work for COVID. We don't want to use all our resources of remdesivir in patients who have the flu. So we have to be quite careful in our selection. We've also done a lot of cross-training of our staff. So our PAs and NPs that are covering the floor and med-surg units have been trained over the last several months to cover ICU as well. And we're doing that with our regular staff. So it's not just our intensivists who are well-trained in how to treat COVID, but it's our regular staff as well. That being said, I'll come to your original question, and that was reports of, I believe, children, right? Yes.
Yeah, that's correct. That was the question. If question was from Chase from Smithtown, asking if children are more susceptible to spread the virus, and if you could speak.
Sure. So a review of the latest available data indicates that while children who are infected with COVID-19 are more likely to be asymptomatic and less likely to experience severe disease, they do seem to be capable of transmitting disease to both children and adults. What remains unclear and where the evidence is still needed is whether children are less likely to be infected than adults. So we don't know that. And when they are infected, what is the frequency and extent of their transmission? There does seem to be some evidence that there is an age gradient, meaning that younger children are less likely to spread the virus and older children are more likely to spread the virus. But there is, that has not come to conclusion. So the children are not more susceptible, but when they do get ill, they tend to be more asymptomatic and have milder disease, and they can be considered vectors.
Thank you so much, and thank you for giving that really extensive explanation and description of where Long Island Community Hospital has really worked with our community to get us through this pandemic. If you're just joining us now, we're live here on Facebook. I'm Assemblyman Doug Smith, and we're here with Dr. Dean Babich, the chair of the Department of Medicine from Long Island Community Hospital. We are also joined by Mr. Richard Margulis, who is the president and CEO of Long Island Community Hospital. Our next question comes from Sophia from Smithtown, who asks, are we studying the virus itself as to whether or not it has a lifespan on various materials, such as cardboard boxes or countertops? So does this virus live on surfaces?
Right. Well, just to not to be too detailed, but the virus actually doesn't live. It becomes active or inactive. It's a particle. So they don't live on surfaces, but they can remain active on surfaces. And yes, the National Institute for Health has studied this. They studied the viruses on plastic, stainless steel, copper, and cardboard. And they also studied the virus in aerosols, meaning when it's aerosolized in the air, to kind of give us a timeline of how long they do become active. The COVID-19 remained active on plastic and stainless steel surfaces for as many as 2 to 3 days under the conditions of the experiment. So that's quite a long time. It remains infectious for up to 24 hours in cardboard boxes and 4 hours on copper, interestingly. The virus was detectable in aerosols for up to 3 hours. And the times obviously would vary on real world conditions. This is in a lab. And depending on those factors, such as temperature, humidity, ventilation, and the amount of virus that is actually deposited on these surfaces. The results do suggest that we could potentially obtain the virus after touching contaminated objects and then bringing the virus to our mouths with our hands, because we do have a tendency of touching our faces. So it is possible. We cannot bring, however, what we've done in the lab to a real world experience. I mean, it's unusual that we would be in an area, except for indoors, and we can talk about that later in the program, where air is moving, right? So most rooms do have some form of ventilation, and there is some form of air movement. So the virus that are living in or that are active in aerosols up to 2 to 3 hours may have an actual much less activity times. In addition, there is something known as the inoculum, or the amount of virus that you actually have to inhale or take in to become infected. So it's not one viral particle, it has to be a dose of that. And that will also depend on how much of the viral particles are actually on the surfaces.
Okay, great, thank you. I think that's a burning question that a lot of people have been asking. Next up, we have a question from John from Holbrook. And I think he's talking about, he says, is the 6 feet specifically to address someone sneezing or coughing, or how saliva enters the air, or is there more to the 6 foot rule? I think he's referring to encouraging people to stay about 6 feet away.
Right. The six foot social distancing rule, as they say, or the 2 meter rule. The 2 meter social distancing rule assumes that the dominant route of transmission is through what we call large droplets that we spew as we speak. Specifically as we sneeze and as we cough. But this one size all fits all does not work when it comes to the 2 meter rule of 6, because there's actually a continuum of the size of droplets. So while large droplets can travel up to 4 to 6 feet, smaller droplets and the aerosolized droplets that leave the mouth and are actually thrust as we speak, or as we yell, more so, and obviously as we cough and sneeze, even further so. And so it is known that the smaller airborne droplets, vaporized droplets, can spread up to 8 meters or 24 feet, hence the need for masks. There is limited direct evidence that it is those little droplets that can travel that far that would have enough viral particles, again, have enough of an inoculum to actually infect us. But I think so long as we do not know this, we have no direct evidence that it is, we also don't have direct evidence that it is not. So we go by the 6 foot social distancing mainly because of the size of the droplets and how far they would travel.
Okay, I think you dovetailed perfectly into our next question, which comes from Andrea from Centereach, who is asking, and it's kind of a long question, but it goes into, she's asking, do the masks help prevent the spread of coronavirus? Are any masks better than other masks? And also, she's saying that there's been a mixed reaction since initially scientists and doctors advised that masks should be reserved for the medical community only, and then now we've seen the recommendations have changed, recommending that all of us wear masks. Could you speak to the science behind this or the effectiveness of the masks?
Right. So the masks, when we're talking again about large droplets, the masks are actually preventing that. So we wear a mask not to protect ourselves, but to protect the people around us, right? So that we're not spewing these large particles. The regular face masks or surgical masks, as is commonly known, the ones with the ear loops, the ones that we wear outside, do help prevent the spread. They do not prevent, however, some of the micro droplets. So if anyone who's ever worn a mask also wears glasses, you'll notice that right away, if you're wearing the glasses and breathing through the mask, you're getting vapors that are causing your glasses to fog up. So clearly they're not preventing everything. What they are preventing is, again, the large droplets, some of the smaller droplets, and then they're also preventing that thrust, the thrust of those droplets, because there's a barrier. So, as we speak, they're being kept to us rather than going to someone else. Are there masks that are better than the surgical masks? There certainly are. The surgical masks do not fit tight, right? So you have air coming out from the sides and behind us. There are something called the N95s, which I'm sure we've all heard of. They are tight-fitting masks that don't allow other air, so they don't allow particles to skip around the mask, if you will. The change in the mask policy is actually interesting. It came about for 2 reasons. One is that there was an increase in the prevalence, and as the increase in the prevalence of the disease raises, then it became more important for us to wear masks to prevent further spread. And at the same time, it was that we became to realize that asymptomatic carriers could also spread the disease. So it became at that time mandated that everyone should be wearing a mask, because even though we don't have symptoms, we may be spreading the disease. So if we all have a mask, we'll prevent spreading to others.
Okay, great. And if you're just joining us, I'm here, Assemblyman Doug Smith here with Dr. Dean Babich, the chairman of the Department of Medicine from Long Island Community Hospital. And Long Island Community Hospital is fortunate, and we're fortunate enough to be joined by them to give us a COVID-19 update. Our next question comes from Beth from Selden. Does it make sense, or can it be detrimental in any way to wear a mask while walking outside alone, or while walking, running, bicycling outside? And the more, I think, pointed question, is it possible for the virus to simply just be in the outdoor air?
Right. So we talked about the aerosolization of the virus, right, in closed rooms and how it can remain in the air for 2 to 3 hours. Again, those are under ideal laboratory conditions where there's no movement of air. Assuming that we're on a bike trail and someone who was affected with COVID sneezed, right, and that can spew around 24 feet, even then, the risk of acquiring the virus as we walk by is going to be relatively minimal, so long as the person isn't there anymore, because there are air streams that are then diluting that vapor, if you will. So if we're alone outdoors walking, running, or riding our bicycle, the risk is extremely minimal, so long as there's no one around us. Adding a mask to that would probably not reduce that risk any further. In other words, the risk is already so minimal. To add a mask to that while you're alone outside is probably not really making any effect to decrease the risk. Wearing the mask, again, decrease risk. It doesn't take it away completely. And so when the risk is so minimal, adding a mask probably would not. change the risk of obtaining the virus in that manner.
Okay, thank you. And the next question, and I know you've actually addressed this, but if you could just mention it again. Marty from Lake Grove, what is the effectiveness of hydroxychloroquine?
Right, so hydroxychloroquine is known to have some antiviral properties. It was one of the first medications that were somewhat recommended by the Infectious Disease Society, and it was the only drug we had. So when you tell someone who has what was considered to be a terminal illness that there is a medication that may be effective, it'd be very difficult as a physician or as a patient not to take or not to prescribe that medication. It was encouraged, and we were using it. We were watching it, but then as the pandemic evolved, it became clear that the antiviral properties were not very strong for hydroxychloroquine against COVID-19. And in fact, some of the side effects or some of the adverse effects of hydroxychloroquine were evident. And that is something called a prolongation of a QT interval, or basically changes in our EKG or the heart rhythms that could then actually have adverse effects for our patients. So we stopped using the drug. It's now no longer recommended by the Infectious Disease Society, who makes recommendations based on evidence to be used for COVID-19.
Okay, thank you. The next question we have is Lisa from Manorville. She is asking, this is what she asks, are the benefits of all that we are doing, including social distancing, quarantining, shutdowns, outweighing the detriments or unintended consequences? And she notes, which includes, people avoiding medical care or the treatment or postponement of medical care. That's her question. I guess largely, is what we're doing working and helping?
Right. We can look at this. I'm going to break it down into several different areas. Is it decreasing the pandemic? Are we having less cases of the virus? I would certainly say yes. These social distancing recommendations, the 6 feet, the wearing the mask, washing your hands, has caused a decrease in about 38% of intermingling or individuals coming in contact with each other. So by decreasing that 38%, it is estimated that we would decrease the peak of the infection by about 50%. That will allow us to get proper health care for the COVID, and that will actually kind of what they call that spreading the curve or flattening the curve. So that has been effective. Economically, if we include wages lost by employers, the decrease in revenue, we're talking about $23 billion in total, just in local communities or New York. But if we look at the cost of treating patients, ICU patients, patients in the hospital, the net positive is actually $5.2 trillion in saved revenue. That was published by the Department of Economics at the University of Wyoming in the Journal of Benefit Cost Analysis. So it's actually been studied, and it is beneficial both for the virus and economically. When it comes to healthcare and I want to say delaying healthcare, those unintended consequences, I don't know if we've fully seen at this time. We saw, as the famous quote was, overnight, our chronic diseases disappeared. Suddenly, no one was coming to the emergency room with strokes. They weren't coming with GI bleeds. They weren't coming with heart attacks. They were all COVID patients. In the past, in the pre-COVID era, if we want to call it that, patients would come to the emergency room if they had some chest discomfort. Many of those patients would be diagnosed with what we call atypical chest pain. They were not having heart attacks. There was some other cause. They were worked up. They were sent home. Now, what we see are not atypical chest pains. We're seeing myocardial infarctions because people are still afraid to go to hospitals. So people are presenting later in the course of disease. We're not seeing TIAs or the transient ischemic attacks. We're seeing strokes because people are ignoring their symptoms and then coming in when they can no longer ignore the symptoms. In the outpatient setting in my office, I'm seeing patients that I had seen last year who were missing appointments with their primary care physicians and had missed appointments with me, whose medications ran out, and they didn't call the doctors for refills, or they didn't want to go to the pharmacies to renew their medications. And so we're retreating hypertension that was once controlled that had been uncontrolled now for 4 or 5 months. So the long-term consequences are still not known, but we're starting to see them as people who can no longer ignore their symptoms are coming out during this period where we don't have a good number of COVID patients.
Thank you. If you're just joining us, we are taking real questions from Long Islanders that were pre-submitted to our panel, and we're joined by Dr. Dean Babich, the chair of the Department of Medicine from Long Island Community Hospital. The next question comes from Diana from Lake Grove, who asks, are immune systems in essence being weakened by quarantining and distancing so that when we do gather, we are more likely to get sick, not necessarily coronavirus?
Right. So we build our immune systems by being exposed to different diseases and or disease processes, whether it's bacteria or viruses. And I think that anybody who has children know that the kids used to go back to school in September, and by mid-September, end of September, the whole house was sick, right? You know, the kids went to school, they wet their noses on their sleeves, they talk to each other, they spit on each other, they drool, they do all these wonderful things. And you have a group of people that all get together in September, and by the end of September, we're all sick at home with colds and flus. So that's how we build our immune system. Does the immune system actually weaken if we're not exposed? No, the immune system doesn't weaken, it just doesn't build. So for a majority of us adults, we've already been exposed to a good number of illnesses so that we wouldn't necessarily weaken our immune system. We're just not building it at this point.
Okay, thank you. The next question is Suzanne from Santa Mariches. We hear that there is supposed to be a strong flu season this year. What would be your recommendations for treating the flu, or for, as it's impending, dealing with that?
Right. Well, the best way to treat the flu is to prevent it. And the same measures that we're using to prevent COVID will be used to prevent the flu. And that is, obviously we're all going to be wearing masks for this season, which is great. We're going to be washing our hands more frequently, and we're going to get the flu vaccine. As I had mentioned earlier, there should be a real strong push for the flu vaccine this year. There is treatments for the flu. We do use Tamiflu. It's been shown to be relatively effective in shortening the course of the disease. But the best treatment is prevention.
Okay, thank you. Mike from Smithtown asks, currently, after having the highest, it appears that New York State has some of the lowest transmission rates in the country. Can you speak to medically why this may be? Right.
New York was hit hard and fast. When we look at the curves from New York, we were the first area to get hit. We reached a peak sometime in mid-April with 60,000 people hospitalized, and that was mostly in the metropolitan area, Long Island, lower New York. The second peak that we see throughout the rest of the country also interestingly reached 60,000 hospitalized patients. Of course, that's over the rest of the country nearly. I think the reason why we've had such a decline and why we've been able to keep the virus under control is that since we got hit so hard, New Yorkers are afraid. New Yorkers are wearing their masks, they're washing their hands, and they're keeping socially distanced. From what I've seen on the news, that's not the case in many other parts of the country. And unfortunately, many other parts of the country did close, but they closed before the virus had actually taken a hold. And then they started opening, assuming that the virus wasn't going to spread. So there was some opening as the virus had spread. And once percentages of the population had already become infected, closing down at that point, it was just a question of how much longer we would reach that 60,000 level again. So I think that New York, by being hit so hard and so fast, we learned our lessons quite well.
Yeah, I would happen to agree with that as well. Laura from Ronkonkoma now asks, she says, now that we have slowly reopened and we seem to be staying pretty low in the hospitalizations and deaths, what advice would the medical community offer to New Yorkers to stay as safe as possible?
The same thing we're doing now, that is maintain social distancing, wear a mask when you're out in public, and wash your hands often, try not to touch your face. That's the best thing we can do. Are we ready to open completely? I would say not. As we enter the winter months, there's going to be more and more of us that stay indoors. And again, that's the area where the ventilation, the movement of air, and the spread of the virus will be more likely. So social distancing, wash our hands, wear a mask.
Thank you. And the next question, it comes from Julie from Holtzville, and I know this is one that I've gotten asked at my office. Is there a consensus on a pending vaccine? Will it be safe, and will it be worth taking?
Right. Well, right now there are 4 vaccines that have entered a phase 3 trial. Phase 1, we look at efficacy and safety on a small groups. Phase 2 on large groups, and finally phase 3 are thousands of people who are receiving these vaccines, so we can study both safety and efficacy. With those large and then a 4th phase, I do not believe that we will have a vaccine that is unsafe. The way these studies are going now, these studies are halted whenever there's any question of safety. And you may have heard in the news, I think it was 3 or 4 weeks ago, that 2 of the studies were halted for a short period of time to determine whether or not it was actually the vaccine that had caused some of the ill effects, or if there was something else that had been missed in evaluating these. So I do believe that the vaccine will be safe. And I don't have any science to back this up, but I believe that we should be having the vaccine by, I'm going to say, the spring or sometime after the winter time. And we do need it. We can't keep living the way we are now. We need the vaccine.
Okay, thank you, Dr. Babich. And again, if you're just joining us, we're here live on Facebook. We are joined by Dr. Dean Babich, who's the chair of the Department of Medicine from Long Island Community Hospital. We're also joined by Mr. Richard T. Margulis, who is the president and CEO. I'm Assemblyman Doug Smith, and we're reading out questions from Long Islanders. So the next question is Pauline from Islandia, who asks, or who says, although the pandemic caught the world off guard, given the history of pandemics, were there things that Long Island Community Hospital had in place that allowed the surge to be as manageable as possible?
Yes, we did. And I actually may turn that question over to Mr. Margulis, who very early, I must say, as early as January when we started having these meetings and finally the COVID task force. I think at that time, we all kind of realized that this is serious, but we still all had in the back of our mind that maybe this isn't going to be as bad as we thought. But yeah, there's definitely, we weren't caught off guard insofar as the emergency management was concerned. We were caught off guard by the infectivity of the virus more so than that. But again, I'll let Mr. Margulis answer that question because he was the lead in managing or preparing us for this surge.
I think Dr. Babich answered the question. I don't think that we were caught off guard. All hospitals have to have emergency management plans. It's good management, it's good leadership. Our plan was in place, it was sound, it was intact. Where I think the world was caught off guard was with the intensity and the speed that this disease kind of went through the land. What we learned from it is it just reinforces our message of constant readiness and always being prepared and never let your guard down. And that's, quite frankly, that's the hospital's mottos when it comes to emergency preparedness and emergency management.
Okay, great. Our next question, and I think actually from your presentation, it makes the community feel very good to know that right in the heart of our community, there is Long Island Community Hospital that seems to be always prepared and ready to tackle any challenge. So thank you for that. We have a question from Maria from Farmingville. Is your facility preparing for a second wave? And if yes, what is believed to be the probability of that second wave coming?
So we do believe there will be a second wave. The nature of that second wave is still not clear. Will we see, again, significant illness or overwhelming of our intensive care units, or are we going to see a blunted disease? That's still a open question. Clinically, we're preparing by going over workflows and order sets, what we call order sets, that allow our physicians to use the appropriate medication to treat the disease process, whether it's the steroids, as I've spoken about before, remdesivir, oxygen therapies, and ventilators, and what we call proning, or placing patients on their abdomens to allow for a better oxygenation. So in that sense, we're preparing our clinical staff. In addition to that, and I may turn this over again to Mr. Margulis, I know that we have increased the amount of PPE that I don't want to call it hoarding, but for lack of a better word, I would say we're hoarding PPE medications not only for treatment, but for sedation and maintaining patients on ventilators. We've increased the amount of equipment that we know we will use because we learned quite a bit over those 100 days, whether it comes to pulling catheters, tubes that we use with the ventilators, central lines or IV lines, IV fluids, all those regular medications that we need for maintenance, as well as the medications that we use for the virus itself. I don't know, Mr. Margulis, if you have anything else to add insofar as preparation when it comes to, of course, cross-training of the staff, I think I mentioned earlier. But I think, yes, we are certainly preparing for a second wave. And again, just like the first wave, we're preparing for the worst, but hoping for the best. You're muted, Mr. Margulis.
You were a little garbled there, but what you said was medically we're prepared. From an equipment perspective, we're prepared. We are anticipating a second wave, hopefully not as severe as the first. That's what we believe. We will be ready. We are ready. We continue to keep our emergency management plan active. Our COVID-19 task force, which is our emergency management task force of management throughout the facilities, meets on a regular basis every 2 weeks. We're moving that agenda forward to project, are there new equipment needs, keeping on top of, as Dr. Babich was saying, the new clinical findings, staying abreast of medication management, supply management, new supply chains, more importantly, supporting our staff and communicating our message to our community.
Okay, thank you so much. And I think Dr. Babich's connection might be a little frayed there because we're having some audio challenges. But our last question, maybe Mr. Margulis, if you could help us with it, is Randy from Finlandia, who is asking, are there things that the public can continue to assist with, such as donations of PPE?
Well, the first thing that I would say here is wear a mask, wash your hands, socially distance yourself, be kind to others, and stay safe. I think what we're seeing is COVID fatigue, and people are starting to forget about what is good practice here. So those are the first things that I would recommend to everybody who's listening tonight or watching. The other is that certainly our hospital, we've been the benefactor of a lot of gifts and a lot of outpouring of our community. We are tremendously appreciative for that. We continue to take gifts, whether that's a luncheon for our staff, whether it's masks, other equipment, whatever it possibly could be. It goes to good use here in our hospital, and our staff, our heroes, deeply appreciate every effort by the community to support them and to support patient care here.
Thank you so much, and I think that's a great note to end on. So if you'd like to say a couple extra words, Mr. Margulis, and we just thank you so much as president of Long Island Community Hospital to make yourself and your staff available to take Long Island's questions, and we are just so grateful for everything that you've done. And if you want to say a few words, and we also thank Dr. Dean Babich as well.
So thank you, Assemblyman Smith. Thank you, members of the audience tonight. Again, this is part of our commitment, our outreach to our community, the communities that we serve, is to be available and to let people know that your community hospital is ready, willing, prepared to deal with any type of an emergency. And we're here, and we will be. We operate, obviously, 24 hours a day, 7 days a week, 365 days a year. That doesn't change. The one thing that I would leave you is, or maybe two things that I would leave with, is again, thank you all for your support. It has been, I just cannot express how much of an impact that has on our staff to know that people really care. And the other is, as Cynthia said before, this is our Heroes Week. We normally have an employee barbecue during the summer where we get together, we share hamburgers and all the barbecue trimmings that you have. We couldn't do that this year because we have to be role models for society and for our community. So we have to practice our social distancing. But we did have our Heroes Day. And again, the word hero has taken on a lot of different meanings. We all know what it means, but it does not in any way really depict what the people in our hospital have done during this crisis in healthcare and crisis in society. They have gone above and beyond every day. They're dedicated, compassionate people. I think many times we see people a certain way and then we see them through an act of kindness or through something else that they do or they say, and all of a sudden they look differently and they are different. I would tell you, as much as we admired everybody who works in this hospital, our entire team, there is nobody in our organization, nobody who doesn't view somebody else as a friend, a colleague, and really a safety officer who looks out for one another. And that's the best message I can deliver.
Well, thank you so much. And I just think in closing, and thank you to so many people who tuned in with us. On behalf of myself, Assemblyman Doug Smith, and our Small Business Emergency Task Force, we want to thank again Long Island Community Hospital, Mr. Richard Margulis, the President and CEO, as well as Dr. Dean Babich, the Chairman of the Department of Medicine. I would also like to take a moment to again thank the members of our great, fantastic task force. We have Mr. Jim Cotgreave, who's the president of Cotgreave Insurance Agency. We have Rick Amirati, president of the Holbrook Chamber of Commerce. Kevin Himes, president of the Ronkonkoma Chamber of Commerce. Michael Wentz, president of the Farmingville Hills Chamber of Commerce. Lenore Paprocki, president of the Middle Country Chamber of Commerce. As well as our other task force members, Kevin Guilfoyle, Diane Cadullo, Tom Lohr, Marissa Paiza, and Suffolk County Legislator Anthony Piccirillo. We thank you for joining us, and we think that tonight was a very productive evening, and hope that everyone continues to do well. And we will get through this together. And as Mr. Margulis very perfectly pointed out, I think that our community during tough times, the best of us really does come out. So thank you, and have a great night.